Welcome back to the Deep Dive. Today, we're embarking on a truly foundational exploration. We're diving deep into a stack of source material that reviews the classic papers, the landmark research that have fundamentally shaped the field of orthopedics.
Indeed. And our mission today really is to unpack some of those foundational concepts, look at how techniques evolved, and critically explore the nature of research and evidence itself within orthopedics.
Exactly. And as the source material highlights right from the start, this isn't just about creating a simple list. There's a fascinating challenge. What actually makes a paper classic?
Well, it's not always straightforward, is it? Many journals might default to metrics like citation frequency, aiming for something objective.
But the editors behind this review realized that just counting citations, well, it doesn't always capture the true essence or the lasting impact of a paper.
That's spot on. Citation counts are, one piece of data, but they don't tell the whole story.
They don't necessarily correlate with genuine transformation in the field.
Precisely. They found that this sort of number crunching, while giving you a rank, didn't always highlight the papers that had truly shifted thinking or practice. So their goal was to add substance, to look beyond just the numbers.
And they landed on a richer definition.
Yes, a more nuanced view. A classic paper, they argued, is one that left an indelible mark. Perhaps it was one of a kind when published, and crucially, it had a significant impact. It changed clinical opinion, or it steered future research in a new direction.
That makes a lot more sense. And they give examples that really illustrate this point, don't they? Even papers that might seem like lower-level evidence today.
Absolutely. Think of Sir John Charnley's work on total hip replacement, or Dr. Ignacio Ponsetti's methods for treating clubfoot.
Case series, essentially.
Exactly. Level 5 evidence by today's hierarchy. Yet their influence on practice globally was, and still is, just immense. They didn't just add to the literature, they fundamentally reshaped treatment for millions.
So their clinical impact really cemented their classic status, regardless of the study design itself.
That's the key distinction. It's about transformative influence, not just statistical rigor in isolation.
And this source material covers a huge range: hip, spine, knee, hand, basic science, trauma, pediatrics. It's a real journey through orthopedic history.
It is. And navigating this history with us, helping connect these pivotal moments, is our expert guide for today.
I'm delighted to explore these landmark contributions with you. It really is like peering back at those moments of major breakthrough.
Okay, let's really get into it then. Building on that idea, defining classic by impact, let's dive straight into total hip arthroplasty, THA. The source calls it one of the most successful operations of the 21st century.
Arguably, yes. And its history is traceable right through these key papers.
It's an incredible success story, definitely. But it wasn't a straight line to success. You have the initial groundbreaking work, Charnley's low-friction concept, for instance.
So the early days had problems.
Oh, yes. The source details the disappointing results with the first-generation cementing techniques. And perhaps surprisingly now, early uncemented implants also faced significant hurdles.
So it's a learning process.
Absolutely. Continuous refinement driven by observing failures and trying to understand why they were happening.
And a big part of that early understanding was tackling this problem they initially called cement disease.
That's right. Early on, they noticed bone loss, osteolysis, mostly around cemented implants. So naturally, the assumption was the cement itself was the problem.
Hence the name.
Exactly. But then a really pivotal paper by Goldring and colleagues in 1983 shed much more light on it. They did detailed histological assessment.
Looking at the tissue right at the implant interface.
Yes, that thin fibrous membrane that often formed between the implant and the bone, especially where you saw this bone loss.
And what did they actually find there?
They discovered it was packed with macrophages, immune cells. And crucially, the tissue had a distinct organization, surprisingly similar, actually, to the synovial membrane lining joints.
So an inflammatory reaction.
A significant one. These macrophages were actively producing high levels of pro-inflammatory things like prostaglandin E2, PGE2, and collagenase enzymes that can break down bone and collagen.
Right, so it pointed towards a biological response, not just the cement failing mechanically.
Exactly. That shifted the focus. But then came another crucial turn in understanding.
Which was?
They started seeing these same little lesions, this bone resorption, around cementless implants too.
So it couldn't just be the cement.
Precisely. That observation proved unequivocally that cement wasn't the sole cause, maybe not even the primary cause. The understanding evolved dramatically.
And that led to the term we use now.
Yes, particle disease.
Yes.
Osteolysis around implants is now almost universally understood as particle disease.
Caused by the tiny bits of wear debris from the implant surfaces.
Spot on. The mechanism, refined through work by people like Willard and Semlich and Anthony and colleagues, is essentially this. Mechanical wear at the articulating surfaces, the ball moving in the socket, generates tiny particles.
From the plastic or metal or ceramic?
Yes, whatever the bearing surface is made of. This debris gets ingested by macrophages, phagocytosis. This activates the macrophages.
Prompting them to release those inflammatory chemicals Goldring identified.
Exactly, which in turn stimulate osteoclasts, the cells that actually resorb bone. Willard and Semlich really described this cellular reaction well.
And Anthony added the migration piece.
Yes, suggesting polyethylene debris could migrate through tiny gaps, maybe between the implant and cement, or implant and bone in uncemented cases, reaching the endosteal surface and triggering resorption there.
So while the exact molecular pathways are still studied,
The fundamental concept was established. Accessible wear particles drive inflammation, leading to bone loss and loosening. That was a massive leap forward in understanding why THAs failed.
that conceptual shift from blaming the material, the cement, to understanding a biological reaction to wear particles, that's huge for implant design and improvement, isn't it?
Absolutely fundamental.
Now, beyond understanding why hips failed, surgeons obviously needed ways to measure how well they were actually performing. The source mentions orthopedics was maybe a bit slow on the uptake with outcome measures.
Well, perhaps compared to some other medical fields, yes. The need for objective numerical systems to describe a patient's status before and after surgery really became clear in the 1950s. The aim was to quantify results with a single number.
And this started with systems like Larson's.
Right, Larson's 1962 system was an early attempt, a 100-point scale looking at pain, function, motion, deformity, gait. Then came the Harris Hip Score in 1969 from Dr. William Harris.
Also 100 points, but weighted differently.
Very differently. Harris put huge emphasis on pain, 44 points, and function, 47 points. That left very little for range of motion, only 5 points, and absence of deformity, just 4 points.
So, heavily prioritizing pain relief and getting people moving again functionally.
It did. But both Larson's and the early Harris score, while useful steps, had limitations, didn't they? Condensing everything into one number makes it hard to see an individual's specific problems or improvements.
Right. And then there was the Merlal-Debunier-Postel score.
Yes, developed in 1970. It aimed for simplicity, giving individual scores for pain, mobility, and walking ability, often shown in a table. It was later modified by Matta and others, refining the grading, especially for motion, and adjusting the pain and ambulation scales slightly.
And that one's still used quite a bit.
It is widely accepted internationally.
Yeah.
Perhaps less so in North America than the Harris Hip Score, which really gained traction there.
But the source is quite critical of hip scores in general, isn't it? Pointing out weaknesses.
It is, quite rightly.
Yeah.
A major issue is the lack of uniformity between different scoring systems, and objectivity is a concern.
How so?
Well, critical studies showed you could get conflicting assessments of success in the same patient just by using different scores. Plus, many lacked robust validation.
And the Harris hip score itself, despite being so common.
The source notes, even the HHS has only been partially tested for reliability and validity. And this highlights a crucial point made by Smith and others. Just showing a new score correlates with an old score criterion validity. Validity doesn't prove the new score actually measures what it's intended to measure.
Or what matters most to the patient.
Exactly. Does it capture the quality of life aspects patients value? The HHS might not fully do that. Many authors now argue you need to combine these scores with patient-reported outcome measures, PROMs, like the SF-36 or WOMAC, for a fuller picture.
So these scores were a necessary start, but later research revealed their limits in terms of uniformity, objectivity, and capturing the full patient experience.
That's a fair summary.
Beyond functional scores, understanding failure also relied heavily on looking at X-rays, radiographic evaluation.
And interpreting those X-rays after hip replacement brought its own challenges. Take the Barrett grading for femoral cementing quality.
Designed to predict outcomes based on how good the cement mantle looked.
Yes, but studies found poor agreement between different surgeons looking at the same X-ray. Poor reproducibility. Only moderate agreement in one study mentioned. That inconsistency makes it hard to use reliably for comparing results.
And the radiographic signs of loosening itself, what were they looking for?
Early signs included things like the cement actually fracturing, or seeing radiolucent lines, basically gaps or clear zones at the interface between the stem and cement, or the cement and bone.
And how common was that?
A retrospective review mentioned in the source looked at cemented stems and found nearly 20%, 19.5%, showed these radiographic signs. But it's nuanced.
How so?
Well, the source points out that thin radiolucent lines in certain areas, like Gruen zone 1 up near the top corner of the femur, are actually quite common and often don't mean there's a clinical problem.
But wider gaps are more worrying.
Yes, wide lucencies, specifically in Gruen zone 1, are considered strong evidence of actual loosening.
And Dr. Harris, who developed the score, also refined his ideas on radiographic loosening over time.
He did. Initially, he had categories like possible, probable, definite loosening based on how much radiolucency you saw, or signs of the implant shifting or the cement cracking.
But he changed that later.
Yes, by 1993, he'd abandoned probable and possible, focusing only on definite loosening criteria.
Why the shift? What prompted that?
He was significantly influenced by autopsy studies, looking at well-functioning cemented stems from patients who'd passed away from other causes.
And what did those studies show?
They revealed that many of those radiolucent lines seen on X-ray, interpreted as potential loosening, were actually just normal bone remodeling happening next to the cement endosteal remodeling, not a failure of fixation.
I see. So the X-ray appearance wasn't always what it seemed.
Exactly. So Harris refined his criteria to be more specific, later defining femoral osteolysis as a focal area of bone loss, wider than 2 millimeter, distinguishing it from those thinner linear lines. It's a subtle but important distinction, sometimes missed in later papers citing his work.
And what about the socket side, the acetabulum? Was it similar?
Radiographic signs there, mainly a radiolucent line at the cement interface, also correlated with finding the cup loose during revision surgery. If you saw a line in just one zone, the chance of it being loose was low, maybe 7%.
But if you saw lines all around...
If lines were in all 3 zones, the likelihood jumped to 94%. And if there was migration or fracture as well, it was 100% loose intraoperatively.
But again, a nuance.
Yes. Interestingly, the incidence of radiographic acetabular loosening was often much higher than the rate of actual clinical failure needing revision. So the exact relationship between the X-ray look and the clinical outcome remained a bit uncertain for a while.
It sounds like reading post-op X-rays involves quite a bit of interpretation, maybe more art than pure science sometimes.
There's certainly an element of experience involved, yes.
Now, looking at how long these hips lasted, the long-term outcome data from big centers must have been crucial. The Mayo Clinic's Charnley series is a classic example mentioned.
Absolutely. Beckenbaugh and Ilstrup published key reviews of Mayo's extensive experience with Charnley THAs, starting back in 1969. Their follow-up, tracking patients in hips out to 20 years, showed a really remarkable 84% probability of the hip surviving without needing revision.
That's impressive, especially for early data.
It really was. A landmark paper showing the long-term durability of cemented THA with good technique. It also powerfully showed how age influenced outcomes.
In what way?
Patients over 70 had a significantly lower risk of needing revision, only 12%, compared to younger patients under 59, where the risk was higher, around 27%.
That 20-year survival figure really showed this wasn't just a short-term fix. The source also compares different early implant designs, doesn't it, like Charnley versus Muller?
Yes, these were 2 very common cemented stem designs in the early 70s. Stauffer and colleagues reported the Mayo results for the Charnley stem, from a loosening around 24% at 5 years, 30% at 10 years.
And the Muller?
Sutherland and associates reported on the Muller prosthesis, finding a higher rate of femoral loosening, about 34% at 10 years.
So the Muller stem seemed to loosen more often on the thigh bone side. Did the source suggest why?
Yes, several potential reasons were put forward. The curved shape of the Muller stem made getting a perfect, uniform cement mantle trickier. It often ended up slightly angled inwards, invarus, which could concentrate stress.
Other factors.
The Muller stem also had a rather sharp, thin edge on the inner side, thought to increase stress in the cement, possibly leading to fragmentation. And finally, the stem itself was often quite narrow compared to the canal, meaning you needed a thicker layer of cement.
And a very thick cement layer isn't always better.
No, a very thick mantle can actually be weaker than a thinner, well-interdigitated one. So these comparisons fed directly back into improving implant design and cementing techniques.
All learned through meticulous follow-up and analysis documented in these papers. What about using THA in younger, maybe more active patients? The Mayo data showed age was a factor.
Yes, the Massachusetts General Hospital study looked specifically at this challenging group. They reviewed 29 young patients, 33 hips in total.
And the results?
Well, the initial results at 10 months looked okay, but the medium-term follow-up, out to 5 years, revealed a more concerning picture. 57%, over half, showed actual or potential loosening of at least one component.
That's dramatically different from the older patient data.
It certainly is. And they found loosening of the socket, the acetabular component, was more than twice as common as femoral loosening in these younger patients.
Did they identify factors linked to these poor results?
Yes, several things were associated.
Yeah.
Having had a previous operation like a mold cup arthroplasty, being highly active after the hip replacement, having only one hip replaced, maybe putting more stress on it, and having a body weight over 82 kilograms.
So it really highlighted that the demands on a THA are much higher in younger, active people.
Definitely. It showed different failure patterns and stressed the need for careful patient selection. Maybe different approaches in this group. You couldn't just extrapolate the success in older, less active individuals.
That gives us a really comprehensive view of how THA understanding evolved. The breakthroughs, the setbacks, the changing ideas about failure, the measurement challenges. Okay, let's shift gears now. Let's explore classic insights from the spine and then the knee.
Absolutely. Equally important areas with their own rich research history documented here. Low back pain, for instance, ubiquitous, isn't it?
Mm-hmm.
As Baker's review highlights, it has so many potential causes.
And researchers tried pinpointing risk factors.
Yes, Baker also did an epidemiological survey, looking at environmental exposures, workplace, recreation. They did identify some risk factors.
Yeah.
But, as the source notes, translating that knowledge into successful widespread prevention strategies has, well, remained quite challenging, unfortunately.
And treating non-specific low back pain conservatively sounds like a complex area, too.
Baker's systematic review found the literature just incredibly varied, heterogeneous, and often contradictory. Assessing how well different non-surgical treatments work is really difficult because the studies are so different in design, patient groups, and how they measure outcomes.
And this is where Waddell and colleagues introduced their concept of non-organic physical signs.
Yes. Their paper put forward the idea that for some patients with significant back pain-related distress and disability, it might not all be explained by identifiable anatomical issues.
So psychosocial factors playing a role.
Potentially a significant role. They describe specific clinical signs to look for during an examination that, if present, might suggest these factors are important in that patient's overall picture and perception of disability. Sort of screening tool.
Moving to specific pathology, lumbar disc prolapse, what did classic papers show about treatment?
A key reference is a randomized controlled trial comparing conservative care versus surgical discectomy for patients with clear radicular pain confirmed by radiculography.
How did they design that trial?
They initially observed patients for 14 days. Anyone with very severe symptoms or who improved quickly was excluded. Those left with persistent significant pain were then randomized, either continue conservative care or have surgery.
And the results of that head-to-head comparison?
At the one-year follow-up, the group that had surgery, the discectomy, showed a statistically significant better outcome compared to the group managed conservatively.
So, important evidence for guiding decisions in selected patients.
Yes, for those with persistent radiculopathy from a disc prolapse.
What about spinal stenosis, the narrowing of the canal?
Verbius' paper was foundational. He was the first to clearly describe the classic symptoms of neurogenic claudication, that leg pain, numbness, weakness brought on by walking, relieved by sitting or bending forward.
Linked to canal narrowing.
Exactly. And he reported successful results with surgical decompression. Interestingly, he initially thought the narrowing was developmental, an anomaly.
But later research showed otherwise.
Yes, subsequent work, often building on his descriptions, showed that degenerative changes, facet joint hypertrophy, ligamentum flavum thickening, disc bulging, are actually a much more common cause, especially in older adults. Even the age range in Verbius' original study, 36 to 67, suggests degenerative factors were likely involved in many cases.
Shifting to spinal deformity scoliosis, Harrington's name is synonymous with surgery here.
Dr. Paul Harrington truly revolutionized scoliosis surgery. His classic paper described a new technique using stainless steel rods and hooks.
To straighten the spine.
Yes, applying distraction and compression forces to correct and stabilize the curves, usually combined with spinal fusion. His work, refined over several case series, was a major advance over previous, less effective methods and became the standard for decades.
And for spinal trauma, Dennis's classification of thoracolumbar fractures was key.
Hugely important for understanding stability after injury. Dennis emphasized the middle column, posterior ligament, posterior annulus, posterior vertebral body wall.
Crucial for stability and neurological risk.
Precisely. His classification aimed to identify fractures at high risk of neurological problems or mechanical instability, helping decide when surgery might be needed. It integrated biomechanics, injury mechanism, X-ray findings, and outcomes.
Identifying patterns like burst fractures is particularly risky.
Yes, it greatly improved communication and allowed better comparison of treatment results for different fracture types.
And the source also mentions Cloward's pioneering work on anterior cervical discectomy and fusion as another key spine paper. Okay, let's pivot to the knee now. Classic papers shaping our understanding there.
The V, like the hip, heavily researched. Understanding ligament function was critical early on. Markov and colleagues' 1976 cadaveric study was a big step forward in biomechanics.
What made it so important?
They provided quantitative measurements. How much did each ligament contribute to stability in different directions at different knee angles? It moved beyond just description to actual numbers.
So more objective data.
Yes, showing, for instance, how a ligament's role changes depending on whether the knee is straight or bent or the direction of force. This directly informed our understanding of clinical stability tests.
Helping understand why we do certain tests at certain angles.
Exactly what ligaments are being stressed. While manual force application was a limitation, causing some variability, it was fundamental work. Kaplan and Cater also contributed to this biomechanical understanding.
And of course, a huge focus in knee orthopedics is the ACL, the anterior cruciate ligament. What did classic papers reveal about outcomes after injury, especially in athletes?
Noyes and colleagues published important early data on this. They followed athletes with ACL injuries trying to return to sport.
And what did they find?
Even with the treatments available then, only about half managed to get back to their previous level by 1 year. They also reported a worrying rate of re-injury.
And long-term consequences.
About half the knees assessed 5 or more years after the injury already showed radiographic signs of osteoarthritis.
That's a challenging picture. Suggests fixing the initial injury didn't always prevent long-term problems.
No, it didn't seem to guarantee a return to normal or prevent degeneration. And the source notes that despite masses of research since then, there's still no absolute consensus on the optimal ACL treatment.
Why is that still debated?
Partly the difficulty in doing large prospective studies directly comparing surgery versus non-operative management. Which brings us to a really thought-provoking finding mentioned.
Go on.
A retrospective cohort study by Kessler and colleagues. They compared patients with isolated ACL tears treated either with reconstruction or conservatively.
Okay.
Reconstruction did reduce secondary meniscal tears in their group. But surprisingly, the reconstructed knees had a significantly higher rate of osteoarthritis later on, 42% versus 25% at over 11 years follow-up.
Wait, reconstruction led to more arthritis in that study, not less?
That was their finding, despite similar activity levels between groups. Their conclusion, quoted in the source, was that doing ACL reconstruction specifically to prevent OA and maintain function cannot be accepted unquestioningly.
Wow, that really challenges a common assumption, doesn't it?
It certainly does. While it's retrospective data and needs careful interpretation, it dramatically challenged a widely held belief. It remains a critical discussion point.
It forces a difficult weigh-up for patients and surgeons. Potential stability benefits versus a possible increased risk of long-term arthritis.
Precisely. It shows that even after decades of research, fundamental questions about optimizing ACL outcomes persist.
A powerful reminder that research can overturn accepted wisdom. And the meniscus, similar story regarding long-term consequences of surgery.
Yes. Johnson and colleagues' paper on long-term outcomes after meniscectomy from the University of Iowa series, looking back at patients from 1936 to 1956, was very influential. Mean follow-up was 17.5 years.
And their key findings.
A high incidence of poor results after removing the meniscus, ongoing pain, degenerative arthritis, laxity, reduced flexion. Strikingly, 76% of the operated knees showed Fairbanks changes, radiographic signs of OA, compared to only 6% in the other knee.
So a strong link between meniscectomy and later arthritis.
A very strong link. The frequency of unsatisfactory clinical results correlated directly with the number of radiographic changes. It powerfully showed the meniscus's crucial role in load-bearing and stability, maybe not fully appreciated when removal was common.
Even with study limitations from that era.
Yes, lacking detailed stats, pre-injury levels, quality of life measures typical for the time. But the core message about degenerative consequences was clear and drove the shift toward preserving meniscal tissue whenever possible.
And just like the hip, evaluating the knee required scoring systems and classifications.
Indeed. For radiographic OA, you have Albach, IKDC, Kilgren-Lawrence, Fairbank. multiple systems, which makes comparing studies tricky. Fairbank remains popular, probably due to its simplicity.
And assessing cartilage damage during arthroscopy. That sounds subjective, too.
It can be. Brismar and Spahn looked at the reliability of systems like outerbridge grading. Spahn's survey found surgeons felt it didn't differentiate middle grades well.
And Brismar study confirmed reliability issues.
Yes. Good reliability for the surgeon scoring the same lesion again, intra-observer, for normal or severe grade 4 damage, but poor for middle grades. And even worse, poor agreement between different surgeons, inter-observer, sometimes as low as 61%.
So different surgeons might grade the same damage differently.
Quite significantly. Even combining grades didn't fully solve it for distinguishing moderate damage. It raised valid questions about the consistency, maybe even the validity, of arthroscopic grading.
Even visual assessment has variability. What about patient scores versus surgeon scores?
Scores like the Knee Society rating system are filled out by the physician. The source points out the potential for bias. The surgeon might unconsciously rate things slightly better, wanting to show success.
And patients and doctors might rate pain differently anyway.
Research shows they do, which makes comparing physician-administered scores directly with patients' self-reported ones like WOMAC or SF36 difficult. Both perspectives matter, but they capture different things.
Finally, the Tegner Activity Scale.
Widely used, often with the Lysol knee score. Its main strength is evaluating changes in an individual patient's activity level after injury or surgery. Are they getting back towards their desired sport or work level? It tracks progress within that patient.
This trip through the spine and knee echoes themes from the hip, doesn't it? Classification challenges, evolving surgery based on outcomes, the search for reliable assessment. Okay, let's broaden out again. Other joints, basic science insights, and research principles themselves.
Absolutely critical areas. In the shoulder, for instance, Neer's work on impingement is foundational.
What were his key contributions there?
He described the three-stage process for subacromial impingement, the rotator cuff tendons getting compressed. He detailed a clinical test for it and presented anterior acromioplasty, removing part of the bone, as a treatment and surgical access for cuff repairs. Really clarified that common problem.
Down to the hand and wrist carpal tunnel syndrome, very common.
Phelan's paper massively increased recognition. He detailed the classic symptoms accurately, the numbness, tingling, night pain in the median nerve area, and shared his surgical experience, helping standardize decompression.
And Gelberman added objective proof.
Yes, by measuring intracarpal canal pressures. Confirmed pressure is significantly higher in CTS, increases dramatically with wrist flexion from 32 mmHg neutral up to 94 mmHg at 90 degrees flexion, and drops immediately after surgical release. Physiological evidence supporting the compression theory.
Napier's work on hand movement sounds quite fundamental, too.
A true classic. Napier provided a basic functional classification: the precision grip for fine tasks, and the power grip for forceful grasping, the anatomical and functional basis for how we use our hands, a framework for understanding prehension.
And for common wrist fractures, like Cole's.
Gartland and Worley's paper was influential there. They aimed to find factors predicting poor results after a Colles fracture and evaluated standard manipulation and casting outcomes. Studied patients at one hospital, providing practical insights.
Carpal instability, a complex wrist problem.
Kolesnik's concepts were particularly insightful. He focused on the lunate bones position, described the carpus, the wrist bones, as two functional rows linked by the scaphoid, like a rigid connecting rod.
And the ligament connection.
The scapholunate ligament as the key coupling, using a slider crank analogy. He coined scapholunate dissociation for the gap in displacement seen after injury, suggesting it might be more common than static X-ray showed.
And highlighted the long-term risks.
Yes, increased risk of scaphoid non-union and progressive arthritis, what he termed SLAC wrist, scapholunate advanced collapse from that untreated instability.
The source also flags key papers on the triangular fibrocartilage complex, TFCC, by Fisher, Thompson, and Harrison, moving down to the foot rheumatoid forefoot deformity.
The source highlights a salvage operation description, excising the deformed metatarsal heads and crucially repositioning the plantar plate.
What were the advantages?
Two key things. It replaced the foot's weight-bearing pad, often drawn upwards in the deformity, and gave a better cosmetic result by straightening the toes rather than just removing them.
And for chronic ankle instability after sprains, Brostrom's paper sounds significant.
Highly significant. It challenged the belief that torn lateral ligament ends just shriveled up, making repair impossible. Brostrom showed excellent results with direct anatomical repair, crucial as chronic instability affects 10–20% after a sprain.
And later studies supported his approach.
Yes, Cripps's multi-center series, referenced, found anatomical reconstruction like Brostrom's gave better function, stability, and less long-term OA compared to older tenodesis procedures even years later.
But a note of caution from biomechanics.
Waldrop's study showed that even modern suture repairs are initially much weaker, less than half the strength of the native ligament at time zero. Underscores the need for careful protection and rehab to avoid early failure.
That covers a lot of joints. Let's shift now to the fundamental basic science insights that underpin orthopedics. Articular cartilage repair, still a challenge.
Mankin's work really captures the complexity and controversy. How does cartilage heal after injury? True hyaline cartilage or inferior fibrocartilage? Terminology confusion, too.
Relevant for arthroscopic shaving technique.
Very relevant. Mankin questioned if debridement itself stimulates repair, or if changes are due to other factors, like altered synovial fluid. Critical questions.
And where do the repair cells actually come from?
Shapiro's rabbit study gave a key insight for full-thickness defects going down to bone. They found that cartilage-like repair tissue was populated by cells originating from the underlying bone marrow.
Not from the existing cartilage edges.
No, the native chondrocytes didn't seem to participate. The repair cells, fibrocartilaginous in nature, came from the marrow. This underpins strategies like microfracture that access the marrow.
And influencing that repair process, Salter's work on continuous passive motion, CPM.
Foundational. Salter's research fundamentally changed post-op rehab. His experiments show CPM gently moving the joint passively promoted healing with more hyaline-like cartilage in animals, compared to immobilization, which led to fibrocartilage and stiffness.
How did CPM help?
It increased production of glycosaminoglycans, key matrix components leading to better functional outcomes, provided the scientific basis for using CPM machines after various joint surgeries.
And those mesenchymal stem cells from the marrow.
The source mentions MSC's multipotent mesenchymal stromal cells. Building on the marrow's role, studies like Wakitani's explored transplanting MSCs into defects in rabbits, showing they could form chondrocytes, demonstrated the potential for cell-based repair.
Bone regeneration, another area with huge basic science impact.
Absolutely. Marshall Urist's discovery of bone morphogenetic proteins, BMPs, was a landmark. He found demineralized bone matrix, DBM, could induce new bone formation even in muscle.
Leading him to identify BMPs.
Yes, the specific protein factors within DBM responsible for this powerful bone-inducing effect. BMPs recruit stem cells from surrounding tissues into a defect and make them differentiate into bone-forming osteoblasts.
Making them incredibly valuable tools.
Hugely valuable biologically for stimulating bone healing and fusion in difficult situations.
Understanding the mechanical properties of these tissues is also vital. Cartilage biomechanics sounds complex.
As highlighted by Sa and Grodzinski, lab studies testing cartilage under simple compression say provide information but don't fully mimic the complex loading inside a living joint. So extrapolating bench findings clinically is challenging.
But mechanical forces definitely matter.
Oh, profoundly. They affect chondrocyte metabolism and health. That's clear.
And quantifying tissue components needed specific lab techniques.
Yes. Measuring matrix components reliably was important. Farndale developed a rapid spectrophotometric method using DMMB dye for estimating JAGs, key cartilage components, much simpler than older methods.
And for histology?
Rosenberg found safranin O stain binds specifically to the polyanions in GAGs, not collagen. Very useful for visualizing proteoglycan distribution and quantity in tissue sections.
Shifting to soft tissue grafts, ligament graft integration after ACL reconstruction, for example. Understanding that healing is key for rehab.
Vital. Success depends on secure initial fixation, graft integrity, and then biological remodeling, with more hamstring grafts used, partly due to patellar tendon graft donor site issues.
Pain, weakness.
Exactly. Understanding how that tendon graft heals into the bone tunnels is critical for safe rehab timelines. Biological fixation happens as the tendon incorporates into the bone.
And for bone itself, how implants integrate, osseointegration.
Fitzpatrick's analysis gave crucial insights into the mechanics needed. Osseointegration direct bone implant connection requires close contact and minimal micromotion.
Thresholds for movement.
Yes. Over 150 micrometers of motion leads to fibrous tissue. Between 40 and 150, a mix. But below about 20 micrometers, you get predominantly bone forming right against the implant. Fundamental for rigid fixation, especially with titanium.
The idea that bone adapts to load, Wolff's law, is also central.
Jones' paper provided compelling human evidence. Studied tennis players' arms, found significant hypertrophy, thicker cortex, nearly 35% more in men, over 28% in women on the playing side. Helps solidify that loading builds stronger bone.
Turner's work, too.
Yes, demonstrated in animals how different loads affect bone formation, needing load to maintain mass. Proposed rules for bone adaptation based on experiments.
And when bone mass is lost, osteoporosis. What did basic science show was the core problem?
Jaussi's quantitative microradiography of biopsies was pivotal. Showed bone-forming surfaces were relatively normal in osteoporosis, but bone-resorbing surfaces were dramatically increased 2 to 4 times higher.
So the key message was?
Osteoporosis is primarily driven by excessive bone resorption, not defective formation. That fundamentally shifted treatment strategies towards anti-resorptive therapies.
These basic science insights, from cell biology to biomechanics, are clearly the foundation for so much practice. Okay, let's wrap up by looking at the principles of research, evidence evaluation, and scientific communication as the source discusses.
A critical section, this. How we generate and interpret knowledge. It starts with a real visionary, Ernest Codman, back in the early 20th century.
Codman emphasized tracking outcomes.
Precisely. His core idea, revolutionary then, was that to improve, clinicians must systematically collect and study data on their treatments and patient outcomes. His end result system idea.
And his bone tumor registry concept.
Prescient, though it struggled for support initially, highlighted the need for collaborative data collection, especially for rare conditions.
For managing musculoskeletal tumors today, staging systems are vital.
Anneke's system was a major advance. It aimed to incorporate prognostic factors grade, extend to stratify risk, guide surgery aggressiveness, and inform decisions about chemotherapy or radiation.
Based on grade, extent, metastases.
Yes. Endorsed by the Musculoskeletal Tumor Society, MSTS, it became the standard for sarcomas, influencing later systems like AJCC.
And evaluating outcomes after tumor treatment, especially limb salvage.
The MSPS also developed a specific numerical scoring system for that. Uses a 0-5 scale across categories like pain, function, emotional acceptance, support use, gait, satisfaction.
And it's reliable.
Field tested, showed low intra-observer variability, recommended for comparing results of different reconstruction techniques after tumor removal.
A critical, sometimes tricky part of tumor management is the biopsy.
Malauer's paper stresses how fundamentally important a well-planned biopsy is. An inappropriate one, badly placed, too small, contaminating tissue, can lead to misdiagnosis, delays, even needing a bigger, potentially avoidable operation like amputation.
So key principles for biopsy.
Careful multidisciplinary planning involving the definitive surgeon. Small, longitudinal incisions sited correctly for later removal. Minimal tissue handling. Get enough tissue. Use frozen section to confirm. Meticulous closure allowing complete track excision later.
Turning to broader evidence-based medicine principles, the hierarchy of evidence RCTs at the top, the source adds nuance here.
A crucial point. The evidence hierarchy is a useful guide, but not absolute. RCTs and meta-analyses are generally taught for treatment effectiveness due to minimizing bias. But, the source rightly notes, a well-done, non-randomized trial or large cohort study can sometimes provide equally good, maybe better evidence. And as we said with Charnley and Ponseti, impactful case series, level 4, can change practice entirely. Sometimes doing an RCT becomes unethical if one treatment is clearly superior.
So it's study quality and effect magnitude, not just the design label.
Exactly. The source also distinguishes evidence users, clinicians applying appraised evidence from evidence generators, researchers doing the studies. Most clinicians are a mix.
And grades of recommendation systems help users.
They try to. Systems like JBJS's 4 grades or the grade system link recommendations to evidence level. Developed by experts, they offer explicit guidance. Grade A might mean definitely change practice. Grade B, probably.
But potential pitfalls.
A concern raised is applying grades too rigidly, without considering the individual patient's context and values. The heparin example for joint replacement prophylaxis highlights this individual risk matters.
Critical thinking always needed. Appraising different study types requires different scrutiny.
Absolutely. Case reports, level 5, useful for rare things, hypotheses, but high bias risk. Case series, level 5, multiple patients, similar issues, prone to bias, especially selection bias, are the patient's typical.
What to check in a case series?
How are patients chosen? Diagnosis, treatment decided. Data collected accurately. Did authors discuss limitations honestly?
And RCTs, the gold standard, still need careful appraisal.
Definitely. Methodological rigor is everything. Check for bias. Was randomization truly random and concealed? Was loss to follow-up high or different between groups? Proper randomization, number tables, bone surface, is better than quasi-methods.
Also check outcomes.
Yes. Were primary-secondary outcomes clear? Measured well with validated tools? Is the difference found clinically significant, not just statistically? Does it actually matter to patients?
And combining studies in meta-analyses.
Complex projects, prone to error, interpret cautiously. Check discussion for shortcomings. Publication bias, missing negative studies. Language bias, only English studies. Flaws, included studies. Poor methods, variations pulled together. How does it compare to previous meta-analyses?
Finally, the practicalities of scientific writing and publishing in orthopedics.
An evolving landscape. More journals, many open access, online only. Wider reach, maybe more citations, but often processing fees, and maybe not indexed or high impact factor initially.
Key tips for writing a manuscript.
Stick religiously to journal guidelines. Word count, references, reporting standards, like consort for RCTs. Verify citations. Get review supervisor, colleagues, maybe linguistic help. All authors must approve the final version. Submission needs cover letter, conflicts, ethics approval, disclosure of prior presentations.
And journal impact factors not without controversy.
Their calculation is debated. The 2-year citation window might not suit all fields. What counts as a citation or citable item is debated. And national bias exists, researchers citing work from their own country more often, influencing IFs.
And lastly, internal versus external validity.
Internal validity. Are the study's conclusions accurate within that study, free from bias? External validity. Can the findings be generalized to other patients, settings, surgeons? The source note's external validity is often poorly investigated in orthopedic papers. A finding in one specific group might not hold true elsewhere.
We have certainly covered a huge amount today, peeling back the layers on classic papers, tracing the evolution of hip, spine, knee treatments, diving into basic science, and examining research principles.
It really has been a journey through the bedrock of orthopedics, seeing how classic means transformative impact, not just citations, tracing how THA refined through understanding failures like particle disease,
and grappling with the tools, outcome scores, classifications, x-rays, acknowledging their strengths, but also their limits, and the need for the patient perspective.
The basic science highlights that constant quest to understand tissue biology, marrow cells, and cartilage repair, mechanical forces on bone, the power of BMPs.
And the research principles discussion really underscores that critical appraisal is key. Understanding evidence, hierarchies, bias, study design, it's not just about having research, but interpreting it wisely.
It shows orthopedics is dynamic, built on this history. Each classic paper often solved the problem, but raised new questions, driving more research.
Understanding these foundations gives invaluable context for current practice and equips you to critically evaluate new information, seeing how knowledge builds, step by step.
Appreciating the lineage of our understanding, yes.
If you found this deep dive valuable, please do consider rating and sharing it with colleagues who might also find it usable.
And as we look at ongoing debates like ACL reconstruction versus long-term OA risk, or the challenges in true cartilage repair, issues highlighted even in these classic papers, it's clear many fundamental questions remain. How do we best integrate lessons from seminal works with evolving evidence, different study qualities, and crucially, the unique needs of each individual patient? That remains the central, ongoing challenge for us all in orthopedics today.